We'll crack on. So good afternoon, everyone, and welcome to, I think now the 7th in our Optimising Timely Discharge webinar series. Thank you for everyone who's joined our previous webinars. We've certainly evaluated the first 5 webinars recently, and we've had over 300 attendees to the live events. More than 300 people have watched them on demand, and we've got 5-star ratings on our Trustpilot, which is always great for us. What we've found is that the discussions in the chat room are incredibly rich and valued, and people have made individual networks and connections as a result of the webinar. So please feel free to share your thoughts and ideas in the chat room. This is I should say this is a totally safe space. We are recording it for so people can watch it on demand, so you may wish to anonymise where you're from should you wish, and that's absolutely fine, but it is a safe space to share ideas, thoughts, concerns and things. It gives me great pleasure today to introduce Inada-Kim, who's an acute physician at mainly Winchester, but part of the Hampshire County Hospital Group. But importantly for us today, he's National Clinical Lead for Virtual Wards. He's also a National Clinical Director for Infection Antimicrobial Resistance and Deterioration. So Matt has a huge national portfolio, as well as being a practicing clinician, and so is in an ideal position to lead a discussion today on virtual wards, home monitoring, and actually what the current implications for that are in the clinical context with Omicron and everything else, and what the future may hold. Today I'm going to be joined by Wendy, Rees, who's one of our improvement managers and a nurse by profession, who happens to live near where Matt works. Totally by coincidence, so we'll bring very much a sort of Hampshire feel to the webinar, and I'll just sit in the background, sort of chipping in as and when. As with always, if you could keep your devices on mute during the webinars, that would be much appreciated. If you have any questions, feel free to put them into the chat box. If you'd like to ask a question, raise your hand at any time. We'll try and filter that in between us. And I think Matt would like to run a kind of interactive session with a short presentation, but then very much open the floor to a facilitated discussion. So Matt, without further ado, thank you very much, and the floor is all yours.
Well, thank you so much. A very kind invitation, and I'm honoured to join you all. Just to go back, so as Andy says, I'm very much a jobbing clinician at heart and in spirit and in mind, but I have a few other affiliations that I've just picked up along the way. You'll be familiar with what we did with COVID, not only, and I think this serves as a good example of the art of the possible, starting with very much about safety of care. How do we improve the quality of care? How do we stop people from dying? How do we get to people early enough in order to intervene and prevent the worst outcomes? And we were buoyed by early evidence that showed oxygen levels at home predicted mortality quite well. And then based our national policy around that, really, about giving people oximeters who were vulnerable at risk, getting to self-monitor, stopping them coming in when their oxygen levels were normal. I know it sounds like a really basic and obvious thing, but, you know, in the realms of anxiety, concern, worry, and the unknown, we needed to go back to what patients could do for themselves in order to hopefully turn the tap off a bit safely, but also raise the alarm appropriately in a timely way when they became sick. And that table in the bottom right illustrates, I guess, what happened all too often at the beginning, which was mild symptoms deteriorating to very severe ones, and then at a very late emergency presentation. I'll never forget the shift where we ventilated 3 people in resus within 60 minutes, all of whom died within 48 hours. And it was a sobering experience, and one that certainly made me think about this pathway in more detail. We wanted to create another work stream that enabled patients to self-monitor at that point of mild symptoms, to lead to earlier admission where necessary. So this was all about safety to begin with, and quality of care, and improving survival rates with COVID. This was spread in the population like wildfire. Amazon took it on, and we got amazing reviews from Amazon when people were buying oximeters. They were able to quote our guidance back to us, which was fab. People made reports on the news, and lots of supporting information followed, and the data soon followed in terms of the impact on length of stay as well. Mortality rate, intensive care admissions, and the readmissions rates, all pleasing results from a local and regional perspective. International studies proved the same. Our own national evaluation was slightly hampered by the fact that it used variable criteria, and you can't really compare a 20-year-old onboarded for COVID monitoring with an 80-year-old, for instance, and not the fault of researchers, but mainly to do with the fact that a wide demographic of people were being offered oximetry monitoring. But when we were more rigid with our inclusion criteria, it did appear to show an impact, particularly those at highest risk. And the spread was pretty remarkable, with 100% coverage within 38 days, and a model for potentially how we disseminate at scale and speed in the face of a pandemic. The question was then raised about whether the same strategy could also save beds. And when you look at oxygen saturations in ambulance conveyances for patients with COVID, you soon realise that nearly 2/3 of those conveyed and eventually admitted with COVID had normal oxygen saturations at the first point of contact. Now, that is not to say we're doing a bad job in the urgent care services. I don't think that for a moment. And there are lots of other reasons why someone needs to come in with COVID other than hypoxia. But it did point the way potentially for some low-hanging fruit potentially, and we're not talking about small numbers. That bottom right graph shows South Central's data in terms of conveyances versus non-conveyances in the 95 to 100% range. So if 2/3 of patients were conveyed with normal oxygen levels, could we turn the tap off a bit in that group, knowing what we did about the composite ICU mortality and the 5-day mortality within that group? And that led to the two strata of, can we protect and inform patients? Can we protect the healthcare system? And in combination of those two elements, develop a higher quality emergency care service. So the past and the present here was very much thinking about acute care problems with respiratory infections and COVID, obviously, as a key element, and frailty coming to the fore as being our two main conditions of interest. And from an acute perspective, that felt like a natural evolution of where we'd begun with COVID and where we needed to potentially head towards in terms of what lay under the water and beyond the tip of the iceberg, with future developments in chronic and perioperative care to follow. So the virtual care programme was begun with virtual wards being clear definitions about an alternative to NHS bedded care, usually enabled by tech, and that these patients would otherwise be in a hospital bed. So the 4 sets of documents, which I can share links for in due course, focused on what the priorities and operational planning guidance for that was, for virtual wards, for hospital at home type approaches, for acute respiratory infection, and for those with frailty, with an aim of producing 40 to 50 avoided admissions and saved beds per 100,000 population. We've had funding for about £500 million for the next 2 years to try and implement this in every single ICS, and we've gone out to them to ask for their plans to deliver it. Now it's critical they link with what we are doing with urgent care so that we can maximise the opportunity here, because this is a combination of things. It's not just about early discharge from downstream wards, it's about admissions avoided in the emergency department, in the pre-hospital arena, and in the acute medical units, or indeed SDECs. So our two models are the hospital at home, which is a more extreme version where there's more face-to-face delivery of care in people's own homes, and an example being frailty, where there is more need for that depth of review. And then the virtual ward bit, which is more a monitoring service and things that can be done remotely, and that's acute respiratory infections a la COVID. Now, both of these offer substantial safety netting and relief, and what we're trying to do is provide a safe alternative to admission, that just in case admission that we often do quite rightly at times, and maybe this offers an opportunity to just reduce that load across the urgent care sector to a degree. We've been exploring the use of tech, and it certainly looks like it saves man and woman hours when involved in this virtual kind of care environment, and there are loads of models to share. Obviously, it's really critical we do some deep dive into what the governance of all this looks like: the safety, sustainability, staffing, clinical pathways, escalation, how integrated care links this, the digital exclusion and inclusion, and what those criteria to admit and reside that are bounded and fitted into this. And this is a work in progress, and one we really need your help on to develop the optimal principles of how this may work and how it interdigitates with the rest of the urgent care pathway. Great strides have been made up and down the country with implementation across most of the country now of these models. The benefits, you know, being seen in places like Dudley, or indeed in North Tees, in South Tees, across to Cornwall, in Wales, Scotland, and then across on the East Coast as well, in the South, in my patch. So the potential is there and the funding is there. So it's a question of what we can develop at scale within our systems to assist our flow, to reduce those not needing to be in a bed occupying our beds currently. And I guess we're limited by our workforce, quite rightly, but we're hoping that as COVID restrictions ease and our workload hopefully reduces a little bit, we'll have a chance to seek and peep beyond the parapet beyond. So that was a brief overview about, I guess, virtual wards and where we are now with it. And in response to, I guess, our part B question, we've obviously seen the death now of widespread testing for COVID. And I think I'm probably not alone in slightly fearing the future and what that will do for the impact on general practice and also urgent care services going forward. What our plan B will be for this, both for the public, but also our staffing models. Anyone remotely with a sniffle has to stay at home now, and you know that would break our workforce. And how the public will react to this. Because whilst we've described quite clearly what the virtual ward element might be in terms of being fit for discharge from the hospital perspective, actually that's a tiny part of the whole pathway. And what we need to think about are the bits in between. What is the community deterioration pathway? What are the criteria to admit, the criteria not to admit, and what same-day services exist that can turn the tap off? The work led by Tara in the hospital and Fiona, the work led by James in the community, the single point of access work, amazing stuff and stuff we need to really support. And then what that fit for discharge might link to in terms of discharge with self-monitoring without the need for healthcare professionals phoning every 5 seconds, and what we can do with tech to enable it and how that links to general practice. And we need to get into the detail, don't we? Think about the services involved, both in terms of the community and the opportunities within community for intervention and non-admission, urgent community response being a key driver, the CAS service, the ONE services, and how that links with primary care. What we need to provide in order to produce a viable alternative to non-admission. And ESTEC does a fantastic job here. But the question is what we can step up also within the community. And I think with some urgency around integrated care, to actually develop and see that promise through, how it links with CAS 111, single point of access UCR, to actually deliver a better service for patients. It doesn't involve a hospital bed, but actually involves the same access to diagnostics and treatments and expert review where necessary. And this is our opportunity potentially to redefine what we do. Primary Care released this paediatric and adult respiratory clinical assessment service hub guidance a couple of weeks ago. And I think we all need to read it and think about it in our systems to develop that assessment, diagnostics and treatment capability within community settings, because everything doesn't need to be in the emergency department or the back of an ambulance. There's a lot that can be done elsewhere, and our surveys on respiratory infection data show nearly 40% of those tipping up in ED with respiratory infection type symptoms go home within a couple of hours. The argument is they don't need to be there in the first place. So the question is what we can do, what's within our gift to try and develop an alternate model to this and potentially stave off the harms of the abandonment of widespread testing with an alternative that means patients get the access that they really need to healthcare, and that we can deal with the worried well outside of the urgent care pathway. We think this will be a win-win-win-win-win solution in due course. It's in the primitive early stages of development, and really value your ideas, influence and potentially support if you think it's a good idea going forward, because it's going to need the actions of many here across all care settings to actually enable. And our initial target is probably going to be around infection because it's still big, proud, and probably the cause of over 40% of our emergency admissions. But this is not limited to that. So that was a really brief whistle-stop tour of kind of virtual wards, potentially the future, and I guess things that are really plaguing my mind at the moment in terms of the worries I've got for, I guess, the coming months. And I hope that was useful.
Thanks, Matt. That was an incredibly detailed, very rapid overview of things. I don't know about anyone else, but I've got lots of questions, but also could do with some time with just thinking about them. So Wendy, I'm going to defer a little bit. Do you want to ask, is there any questions that you want to bring up first, and I'll come in and I'll put some questions for everyone in the chat to think about?
Yeah, no, what a fantastic sort of vision, Matt. So that was fantastic to see. So I think probably at the moment, and my colleagues on the call from Hampshire will probably agree, is that there are virtual ward models around where we've got sort of, you know, very, very highly skilled multi-professional teams looking after groups of patients for a period of time during illness. But I think what's really good to see is just actually how that links with the whole acute pathway, because I still think we're in a position sometimes where we've got acute episodes that start and finish, and then an acute episode that might start and finish with another team, or might be a hospital team, might be a community team. So I think it's really good to see that sort of tie-in, because I think, you know, there definitely is a role in virtual ward for supporting timely discharge. Absolutely get that, but there is a huge opportunity, isn't there, in terms of alternatives to hospital, but also recognising, I think for me, that we cannot underestimate the value of acute care in hospital for patients that are really unwell, and the drive towards a virtual ward model can sometimes maybe increase the risk by actually making the focus more on keeping the person out, and not utilising what is some of the acute specialist services like SDEC, etc., and linking those pathways up. So I think for me, the question back to you is, how do we recognise what, you know, as a team, how do we recognise actually we're delivering a virtual ward type model, and what are the critical elements that we need to consider to maybe, you know, step it up to the next level?
Brilliant questions, and I think all of us strongly believe that this is about optimal patient care. So I never went into this to save beds, and I'm sorry to say that. It's always been about how do we save more lives, and that's where the model for COVID oximetry and virtual wards was born, and it was a translation of that into bed days saved that then developed the virtual ward funding, because we, you know, unfortunately in this day and age we don't necessarily get the funding for saving lives, do we? Because actually it's cheap death, relatively speaking, and it's sad to say. So we need to bring it back from the brink and back to optimal care, in my head, and I think we will get the bed day savings through doing that, because I think by delivering optimal care we will reduce length of stay. We will impact, I think, on admissions and readmissions, definitely. We've got the evidence of that, and will improve recovery to independent functioning and life quicker. In terms of how we get to that point, I think people need to see the art of the possible. So we've got amazing enthusiasts in virtual wards working in their silos, usually relatively unassisted, quite honestly, and usually doing 60 or 70-hour weeks because of their own unbelievable passion and enthusiasm for an alternate model. And what we've got to be better as a system is, within our very busy other silos, is getting our heads together and thinking how we can support that, because the gains within doing so will support everyone else. So it's the drive towards integrated care for me. So I don't think virtual wards are a hospital thing or a community thing. And I don't think these assessment hubs are the same. I think this is all integrated care, and that if we can nail a model where we have virtual wards and we have assessment hubs with community diagnostics all linked in the same physical hub, served by an integrated team from both the community, the interface, and also the hospital, then I think we achieve that win-win-win. But where we will fail is if we are divided, I think, and are trying to do it, you know, amazingly by ourselves. So I just hope that the maturity of ICSs pick up enough to support this. And whilst £500 million sounds like a lot, it isn't really in the grand scheme of things. And we need substantial investment from ICSs in addition to that, to bolster the assessment elements and to ensure that there is a plan going forward. Don't create a community diagnostic hub in the middle of nowhere. You know, for God's sake, stick it with an assessment area so that you can make the most of that. so it doesn't become a white elephant. And I think those are the sorts of honest conversations we need in every single one of the ICSs going forward, because otherwise I don't think they'll be used as much as potentially they could be. And whilst it's all well and good saying elective recovery, elective recovery, elective recovery, essentially probably the key plank of elective recovery is having a healthy urgent care pathway, because we all know what happens to elective recovery when there is no bed capacity, when there is no flow, and there are patients who are medically fit for discharge languishing all over the system. So we are all part of the same system, and elective and urgent care needs to be hand in hand going forward.
Thanks, Matt. That's really helpful. I can't help but feel we're not very far. We haven't implemented very much of Aradasi's plan many years ago. It wasn't, local care for local people and delivered in an integrated fashion. And here we are, sort of what, 10, 12 years plus, still debating it. You've kindly responded to Kath's point about integration with community diagnostic hubs in the chat, which is really appreciated. We've also expanded on that. We've got another question from Jonathan Holly, which interestingly, looking at his email address from Health Education England regional team, looking at the split between private provision or outsourced provision versus more integrated services. And I guess that also links to the question I have around the workforce challenges and whether there's been you've seen a net reduction in workforce with using virtual wards, or whether you're able to be more innovative in your workforce use in a virtual setting, if you see what I mean. So just linking the proportion of private versus integrated workforce innovation versus traditional models.
Yeah, it's a really good question, and a thorny one. So I guess we all embrace the use of apps, and they're not true private delivery care mechanisms, but they were necessarily funding that went to private companies to innovate, and they did this at some speed. And I was very happily one of the recipients of that in my locality. We stood up a respiratory infection and COVID hub that used this app, which was called In Healthcare, to look after around 4,700 patients with respiratory infections over about 6 months. 200 of them ended up being in hospital. 4,400 remained in the community. And these are the sorts of models you can do if you have, I think, the influence of potentially some private companies that take an interest in it, because we just don't have the innovation headspace, do we, or necessarily the tech within the NHS itself to do these things at speed and scale. In terms of other models, and I can really talk about my locality, we had a private provider that provided the monitoring services for patients. They did a really good job, I have to say, but it was what distressed me about the model was that it was somewhat divorced from my knowledge about what was exactly happening with patients. And maybe that's my controlling nature that I struggled with. I struggled with the idea of just a fire and forget form and then expecting things to be picked up, but not getting the feedback necessarily about what the outcomes for my patient were, and that there was definite receipt and safe handover of that patient. And I saw a lot of that with that division. So whilst I think private healthcare was incredibly helpful in some ways in taking a load off the monitoring of thousands of patients, certainly in the COVID experience with COVID in the community, there was a slight disconnect with the knowledge about what actually ended up happening to those patients in regard to the NHS care elements. So I think the future needs to probably bring in both. We need to play to the strengths of and weakness and understand the weaknesses of both approaches. I guess gone are my days of trying to avoid all private healthcare at all costs, because I think over time I've realised we are not going to be able to do this alone. We will need the assistance of private healthcare in one form or another. The question is what we have most to gain from and where they produce most benefit with least risk. And I think it's horses for courses, but actually also I guess not being as closed-minded, and I'm speaking personally, as I was maybe 5 or 10 years ago in relation to that.
Thanks, Matt. And I guess you're also highlighting the importance of integration, both in terms of sort of private digital companies and digital tech applications, but also with the private providers being able to share information, governance and things. I'm going to, so there is a question from Sally Hawes in the chat around therapy support, but we'll come on to that in a moment if we can, Sally. But Husnan from Queen's just put their hand up. I didn't know whether they wanted to come in with a question.
Sorry, I did put it up. I suppose the question really is, I totally agree with what my colleague here is saying, but I think the biggest factor is challenging the mindsets that we've actually ingrained in our training, that actually it has to be this way. These are medical patients, and actually it's not. We need to change it and say, well, actually, what does that patient need? And I suppose the question is, how do we break down those territorial barriers? Because times are changing. There will be a way to skin every single problem. And I totally agree with you. It's about integrated care. You know, it's not about actually saying, well, you know, this is going to be a patient, because all of those add up. And I suppose the second question is how there will be some kind of, I mean, if you take, because I'm also an intensivist, if you take the critical care outreach as an example, we've put up standards where we say, well, actually, this is the core fundamentals of what a critical care outreach service should look like. It needs to be adapted locally, but these are the core fundamentals that need to deliver. We don't have that for acute medicine. And I think what we really, really need is to actually take on this integrated care and say, well, this is the core fundamentals of integrated care that we need to do. They will need to be adapted locally. And we need to look at that model nationally. And I suppose the question really is there something out there that I've just not been alluded to? And also, how do we break this territorial barriers? Because that's a massive, massive challenge in London in BHRU2. Thank you.
Well, what a brilliant challenge and important concepts. I'm just going to share something I'm trying to write up at the moment regarding the workforce elements, because I think what we really need to do is go back to basics with, I guess, what our need is regarding what you say. And although we need quick solutions, I think there is a workforce out there to be found that doesn't want to do necessarily the traditional model of primary care or indeed secondary care, but wants something in between. We have a significant lost tribe. We have a huge attrition rate in our staff generally. And I think they're crying out for a different and alternate career structure that enables this. So I was thinking about this within what an integrated care workforce might deliver in the, my own narrow area, acute care and respiratory infections. So the why, the what, the how, and what the challenges are in terms of certainly across junior doctors. And this is really a piece that was sent to the head of workforce medically, so apologies for it being less multidisciplinary than it should be, and the Faculty of Medical Leadership and Management. So the ask and challenge of workforce regarding what it is junior doctors in this particular instance are saying at exit interviews as to why they don't want to continue working. Yes. What are the stresses and strains of working through COVID, understaffed, with the huge amounts of work hours, the lack of provision sometimes? And what is it they want to achieve in terms of their future career aspirations? And what can we do regarding, I guess, that nirvana of what we're trying to achieve? What might be an integrated care clinician of the future be part of? What skill set would they require? What can we put in place to make this an attractive career option? And how can we dovetail a potentially more manageable workload within an integrated care hub with the demands of true primary care or more pure secondary care? Is there some sort of job share type agreement we can do to sustain the careers of our workforce, which, in large parts of the country is burning out? So I think we really need an honest conversation about what we've gone through as a healthcare service, the opportunities that exist, I think, for the future in integrated care, and how we can rapidly develop solutions for this. You can call them pilots, you can call them what you will. But what we can't do, in my opinion, is to sit on our hands and wait for our workforce to leave. I think we don't have the time to really I think about this for a long period of time, or years, or however long these programs take to develop, but start actually having the conversations now about what people want to do and what opportunities and employment opportunities potentially exist within these. So sorry, I'm a bit opinionated on this, but I strongly think that we need to
totally agree. And I think we need to have these conversations now, while we're having conversations about how we spend millions of pounds on these hubs, community hubs. You know, we've been there where you set up these community hubs, you've invested so much money in it, and then all of a sudden they're of no use, and you have to break them down and erect something else. Why are we not learning from our mistakes? We have to learn and say, well, actually, what is it that we need? Let's look at what the strategy is going to be for the next 5 years. Clearly, what we're doing isn't working, and let's look at this integrated care model, because it is the only way forward. It really is the only way forward.
To be honest with you, I think the power is going to be with us in our ICSs within our regions and localities. I think if we wait for the national team to pronounce on things, it's going to be long gone. I say this as someone who works on the national team. It's probably not the right thing to say, but you know, we just got to act. We've got to get on with it, haven't we? And you know, if we wait for permission, we're going to be done.
I agree, and thank you very much, Mazrat, for bringing that question in. I am going to move on. We'll hopefully be able to come back to some of these things, because there's a lot of cross cover, if that's okay. I'm going to name people if that's okay, but feel free to not come through. But we got Sally, who I think is a therapist, has talked about early supported discharge and the role of therapies in that role. Sally, I don't know whether you'd like to come in on that in person, and I'm going to come to Rachel if that's okay. Sally, you there?
Yes. It's just really a question if there's going to be investment in a lot of tech, which seems a really positive way forward. But will there also be investment in the therapy services, because they are often underfunded and under-resourced, which is then leads to sometimes delayed discharges and also no options to really discharge patients to pick up the kind of level of care that patients need to be discharged at the back door. So just wanted to bring that into the conversation, as well as a need really going forward to support earlier discharge.
It's a critical area, and you're absolutely right. This is, I'm sorry that last piece was very medically focused, because it's certainly not intending to be that way. This is about MDT solutions and approaches, and the medical side is a tiny fragment of that. Quite right. As soon as you get to frailty and older aged patients, you need the whole package. So it'll be up to ICSs to decide how to invest their money. And what they've been asked to do is go away and have a think about what they want to set up with acute respiratory infection and frailty. So if they're not having conversations with you in the community about MDT approaches and therapy approaches, then they're not hitting the mark of what they need to be doing. Because without that, we're sunk. We're not going to be able to achieve the virtual ward ambitions within elderly patients or frail patients. I'll share all the documents in chat which have kind of gone through this, and so that you're familiar with what the opportunity might be. And then what I implore you to do is have conversations with your ICS about the role, because you know you're not going to be able to send someone home unless they have the adequate therapy support that's required. It's simple. It's a simple equation. And what perhaps would be useful are case studies and examples, so that ICSs don't have to start from ground zero. They've got something to go on. So I'll try and dig up some links and pop them in the chat.
Lovely, thank you very much. And Wendy, can I bring you in on this, because I'm just, for people on the call, I know that you've been doing some work in this field. Have you got any top tips of how particularly clinical team clinicians on the call can engage with their local ICSs or with their local providers around this, from what your work?
Yeah, I mean, actually, I'll probably bring in one of my colleagues, Rachel Mahir, just to talk a little bit about the Frailty Model, which has been really successful across the whole of Hampshire. And I think one of the key things about that, it's building up the clinical relationships across the services, as you say, Matt. They're really important about stepping patients up and having that ability to have clinical conversations about patients and advice and guidance. But Rachel, I didn't know if you wanted to say any more about that, but also to just add in the question that you put in, which is absolutely valid, around it's not just the clinical aspects that we need to consider, it's also the care of patients at home, because not being in a hospital, we do lose that element, and that is actually quite a big ask for patients' family and carers to take on the care of an unwell person. But Rachel, I didn't know if you wanted to say any more about the Frailty Service.
Yeah, absolutely. Thanks, Wendy. So yes, I support the Frailty Service in the southwest of Hampshire, which is kind of the New Forest area, and they have very much they've been embedded for probably 5 years now, and certainly what they have often come up with in terms of challenge is that broader aspect of supporting people to enable them to stay at home, and it is very much, as you said, Wendy, the care provision and that social care model that is absolutely, you know, integral in terms of that maintenance at home, to really increase that. And I think that's something that's always missed or not necessarily as is one of the first priorities in terms of planning. And that often is, you know, we often come across situations where the ambulance team will look at a situation and think there's no alternative, there's too much risk to leave someone at home, and that's why they convey. So actually it is that bit that's really key, and we know that there's some limitations and there's definitely a need for increasing that workforce. But I think alongside that, my other question that I asked is, do we think people are ready for this yet? I think we're doing an awful lot of work on self-management and trying to encourage people to manage their own long-term conditions and to manage certain things at home through different systems. Certainly that starts with the GP and e-consult and things like that. But I do wonder whether people are ready yet, and whether there's something nationally we need to do around talking about how, at the end of the day, we're not going to be able to meet everyone's needs unless they take ownership for their own health, and that they take part in being supported and having a, you know, partnership working, if you like, with clinicians or with social care to help them forward. So I think, you know, there is that bit that I was talking this morning about, the blue boxes that have pulse oximeters and the blood pressure cuffs to be able to do this for patients at home. But a lot of the people I was thinking about probably couldn't manage this yet because we've not embedded this need yet. So I'd just be interested what other people thought, and whether there were other ideas that we can start doing to get people in that mindset. Sorry, big question.
Happy to speak, because I think Rachel's hit the nail on the head. I have to say that I've never believed this as being an all or nothing thing. I've always thought this was going to be stepwise, and you know, actually what we're trying to influence is the behaviour of patients, aren't we, and their empowerment, and the empowerment for carers as well in knowledge, to not only, I guess, look after themselves as best they can do in terms of preventative healthcare, but also to raise the red flag more easily when they are worried and when they are concerned about their health, to lead to earlier presentation and potentially more salvageability as a result of that. So I think it's a double-edged stream here. And I think whilst we've gone down this virtual ward, I was all about hospital admission, go for broke. Actually, there's a huge amount. 99% of it is just optimal care, and all of those elements to personalised care empower patients, provide a safe alternative to hospital admission where that is the case, but actually just get their care right in the community in the first place to mitigate and reduce the instances of deterioration where that is necessary. And where you've had the opportunity to build a relationship, ensure you've got very sensible treatment escalation limits potentially put in place with very reasonable proactive conversations. So I think there's huge amounts we need to do around this space that are not about virtual wards. And I say this as someone working in the virtual ward space. I think this is absolutely about optimal care. And I honestly think that we've siloed ourselves so much over the years that we've missed the boat in terms of optimizing the pathway response to, I think, chronic and acute patients. So I hope we use this opportunity to potentially put that back on the map in a way that, you know, is not necessarily purely around bed days saved, but has more holistic and I think more worthy aims.
So Matt, can I come in on that, if that's okay? And Rachel, thank you for sharing both your experience and the question. And I think there is a real concern, if you look at the evidence around telehealth or telemedicine, whichever definition you use, that there is a real fear about digital exclusion for a significant minority, but it's arguably the most vulnerable groups that are excluded from this kind of thing. So my question, controversially, is that we talk about optimal care, but actually we're talking about optimal health care rather than optimal care, because care is a wider concept than just health. And what I think, correct me if I'm wrong, but from my perspective, what I think we achieved during certainly the first and early second wave of COVID was acceptable care, acceptable health care. So when we talk about optimal care, are we actually talking about optimal care? Are we talking about acceptable care? Are we talking about health care alone? Do you see what I mean?
There's a really clever analysis. I guess from certainly the evidence we're seeing about, and this more lends itself to chronic care, but the early evidence we're seeing from the management of chronic long-term conditions and the impact COVID had on that is certainly showing that there is a lot of harm that non-face-to-face strategies has led to. There's a really great paper that's about to come out on diabetes screening and things like foot pulse examination, peripheral neuropathy examination, eye examination, and the impact that had, together with HbA1c and blood pressure monitoring, on strokes, heart attacks, amputations within diabetes. So whilst this new virtual arena is all wonderful and all shiny and incredible in some areas, we've got to be really careful and take it with a pinch of salt, because actually there's a hell of a lot that still needs face-to-face, not least of which a good conversation with the patient and their family. And you know, whilst I would love a world where we could offer digital tech and be as remote as possible all the time, it's just not the reality of what optimal is in my head. So you're right. This is, maybe we're being too large in saying optimal care, but if we don't have that lofty ambition and embrace the social care elements as well as the healthcare elements, then we're not going to get to where we really want to get to, which is optimal care from cradle to grave, isn't it? And whilst it's easy to say, right, we're just going to address healthcare, and that's big enough, there are so many reasons why patients become ill because of the social care elements. We're all familiar with that, aren't we? Every day we see this. So I think if we don't try and tackle everything as a system and acknowledge each other's challenges, I don't think we're going to make anything meaningful in terms of the ground over the next few years. And with our aging, increasingly comorbid and dependent population, it's only going to magnify. So I think we're all in it together. I would love to see us moving towards that, both in terms of elective and urgent care and in all settings generally. And, you know, we have a blueprint. The question is how much we use it and how much we believe in it.
Great, thank you, Matt. And so just to reiterate, what we're aspiring for optimal care, and that we should not accept anything less in terms of when we're designing systems and putting change in place, and that's what we should be aiming for. I've got another question, if I may, around some of the sustainability of the changes that you saw initially. So you demonstrated beautifully in your talk a very visual graphic of the change of availability of pulse oximeters in the UK. I think it was the UK, it may have been England, apologies for the 4 nations if it was England, over 38 days. I just wonder what the colour of that map looks like now if we went back to do it, and if it's not all blue, why not, and how do we sustain these changes?
Yeah, it's again a really good question. So we've been monitoring and this is only specific to COVID, I'm afraid, the uptake of the more hands-off monitoring of oximetry at home. So that's patients monitoring themselves, led by the community, and virtual wards going forward. And the average is about 1% of all COVID positive patients in the community getting GP supervised COVID oximetry at home monitoring, and around 15% of all hospital COVID primary diagnosis admissions being essentially being cared for in the community using the virtual ward mechanism. There is variation from region to region, from trust to trust. I guess that will always be the case. And what I'm hoping we're going to be able to do is an in-depth analysis of the differences in outcomes between those of low uptake and high uptake, and to actually stratify these by acuity. I think it would be also useful to look at it in terms of deprivation, and then also ethnicity. And then we can start to build a picture of really whether we had meaningful impact here. The difficulty is just the complexities of that evaluation and what level of interoperability we'd need digitally to combine the systems to get to the answer. So the variability is a thing. It absolutely is a thing. I hope we will be able to get the intelligence from evaluation in due course to tell us whether it's made a significant difference, and crucially if it hasn't. But I can't see it happening tomorrow in terms of getting that answer, and it will be significantly down the line. I think one of the things that I think is a really hard sell of this model, and where I think we probably need to be sharing more about it, is the potential labour it saves for healthcare in general. Although I'm a tech phobe and also a lover in some ways, what we found in some of our hubs, and this is a graph showing numbers of patients looked after by these virtual ward patients with COVID during the second to third peak. We got up to nearly 300 patients at any one time looked after by one hub, staffed by 2 advanced nurse practitioners and 1 GP. So can you imagine what that would have, how we'd have looked after those patients with a phone and a pen and paper? And I guess what I'm trying to say is there is opportunity both for safety, quality of care, but I think also crucially workforce saving as well.
And presumably, Matt, that sort of, with your national role on, there's some clever people from the health economics kind of units trying to quantify some of this for us.
I think so, yes.
You hope so?
I hope so, yeah.
I mean, the other thing that just springs to mind, when particularly looking at your Winchester data that you've just put up there, I personally have a mini virtual ward. I've got a virtual list of patients that I'm concerned about, that I keep monitoring. It's not quantified, it's not necessarily captured in a job plan, and I suspect I'm not unusual in that regard from a clinical perspective. I wonder how much of the virtual work is already out there and but unseen and under the radar, and we kind of present this stuff as new working and a panacea for all things for optimal care, let's use that phrase, but actually there's a lot of this that's already going on that people are maybe not acknowledging.
You're
what are
right.
your feelings on that?
No, I 100% agree. And if you think about what we do with an SDEC as well, we're renaming something we probably all have done amateurly for years, haven't we? Usually in addition to whatever other service is bolted on. And I think the important thing to do is to be clever in our business case writing, to ensure that instead of the additional add-on service that we probably carry out with, and I'm thinking about probably at least 5 to 20 patients a week we do this on in, the SDEC that I work in. We need to channel the funding to ensure that it goes to the front line for people delivering those services. We can badge and rename it how you want, I suppose, is the answer, but we've just got to be a bit better at articulating what it is we are doing, and make sure that the funding is delivered to where it needs to go. It is a bit of a game, isn't it?
Well, the analogy is, as you say, ambulatory care, clinical decision units, then it's SDEC, then it's same day emergency care, all those kind of things. Wendy, and before you come in, Wendy, Jonathan's asked a great question, which I'll come on to. So Jonathan, thank you. We'll bring that up in a second. Wendy.
I just wanted, and just very quickly, I know safety netting is probably a whole new webinar, but for the clinical staff on this call at the moment, what are your sort of top 3 tips for safety netting a patient? Just a little practical, something that people can take away today that might just give them a bit more confidence about the work that they're currently doing on virtual wards.
If that's for me, I think know your condition, okay, and for me, put the hours in to develop the guidance, because each time you do it, a stitch saved is remarkable. We sometimes put this stuff out, don't we, without enough due course and consideration for what you've just said. And we did this nationally as well, and I regret that, because we had a stab on it, and essentially it took a lot of eventual effort to actually get a more proper glossy version of it. But we then encountered the problem of once we'd actually agreed it and had some patient information facing safety netting leaflet that we were kind of proud of, with the fact that we weren't able to release and share it because the limitations on the amount of text space we were allowed on every single positive test going from government out to patients. So there's so many barriers in terms of getting it out there, and I actually think that we can probably do better and more on a local and regional level than we ever will be able to on a national level for those reasons. So I would work hard on developing your own around conditions you really understand completely, and make it as specific to the geographies you work in as possible, because national guidance there will refer to your DOS, or refer to your GP, or go to 111. It's just no use. You need stuff that a person will actually realize, this is my local solution for me. It's a personalized solution. And I think some EDs do it really well with their advice cards, and you can write in numbers specific to that particular patient, and that's really helpful. Speaking as a patient, I found that unbelievably helpful. And there are good apps out there that do the same. Now, safety netting information in app form, so that you can signpost with Healthier Together, which is the children's kind of website. They've now turned it into an app where parents can look for red, amber, green symptoms and then get very clear direction, because they've put their postcode in and their child's NHS number of exactly when their GP surgery is open, who's going to be there to receive the call, and out of hours what they do, with what response and with what level of urgency. So I think we should ramp things up to a whole new level of both detail for the patient, but also use tech to assist what will be a challenging thing to do individually for every single patient.
Thanks, Matt. I mean, we could carry on this conversation about the role of the national bodies like the BTS, BGS, BSG, all those kind of things, but we haven't got time, much to my shame. Rachel, I'm going to bring you in, but I don't know, just before I do, Jonathan's asked in the text box, is there any guidance on safe staffing on virtual wards? If there is, we can share it. There may not be, though. Is that? I
think it's a work in progress. And let me see if I can find a link.
So we can put that in the chat box afterwards, Matt, in the interest of time, and then the chat will be available. So thank you very much, and thank you again Jonathan, for your questions. Rachel.
Thank you. I was just going to add around what the discussion just had around risk. And I think the other bit that's really important for us to be very mindful of is working with partners to make sure that we're not taking too much of a risk in terms of not getting people to the right place early enough, and managing people at home when we shouldn't be. And that's the real balance, isn't it? That's just, is worth just mentioning, and having really clear conversations with our acute partners to be able to have that open discussion about when we should and when we shouldn't move patients to a different setting, because that does worry me as well. When we're managing patients at home, there's a cohort that become quite risky, and as you said, it's really important about having that guidance and that clear knowledge about those conditions. But yeah, that's a balance all the time that I think we try and manage.
Thanks, Rachel. And there is, I'll come in just in the interest of time, if I may, but we have done a webinar last week with a couple of our colleagues, Ben Owens, who's an ED clinician at Sherwood Forest, Barath Lakapa, who's one of our clinical associates, who's a community geriatrician, around balancing risk, both in and out of hospital, which I would signpost people to. We are coming to the end of our time. Matt, it's been an absolute pleasure to hear from you and have an opportunity to speak with you. Thank you to everyone who's been part of the call, for the discussions, the questions, and everything that's been put into the chat. I have thoroughly enjoyed today's webinar, purely selfishly, so thank you very much indeed to everyone. The recording will be available on the ESIST YouTube channel. Before you go, Crystal, could you share your screen, because we have a QR code for feedback. We are evaluating these webinars very closely. We're getting very positive feedback. People are enjoying them, but it's really important that we understand if you want different topics, what could be improved, what went well. And so your feedback is invaluable to us. We don't have any more of the webinars in the diary at the moment, but I can tell you we will be running more very soon. So in the next couple of weeks, watch out for social media and email alerts from us. We're going to be doing some webinars on workforce. We're going to do some more diverse webinars. So Sally asked about health inequalities. We've got a public health consultant working with us who specialises in this area, so we'll invite her to a webinar and things. We've talked about safety netting, so if you've got any thoughts about what you would like to hear at lunchtime and discuss, put them in the feedback and we'll do our best to support those. Thank you again for your time. Matt, thank you so much. Wendy, it's always a pleasure. Crystal, thank you for being super behind the scenes. Thank you, everyone. Have a great afternoon and we'll see you again soon. Take care. All the best.